and it's Professor Jalaie. First of all, he's my good friend, but he's a key opinion leader in venous disease. He's a professor of surgery at the University of Athens, very well known in the deep venous interventional field, and we're looking forward to his presentation on a case of chronic venous obstruction. Houman.
So now you should see it.
It's again not full screen. It's like
yes.
Full screen.
Now it is full screen.
Yes.
Yeah. Perfect. Great. Thank you very much, and many thanks to Nikos for the nice presentation, and also Giovanni for the perfect discussion. So Nikos, maybe after this presentation, we should also discuss. So I had to prepare a case of recanalization for chronic venous obstruction. The name was a challenging case, but technically it is not challenging. But the challenging part is maybe the decision-making. So I start with the case. It's a 60-year-old male patient who had 2 years before he came to us, he was referred to us, a PAD, advanced PAD, and for that, he received a below-the-knee bypass on the right leg with contralateral GSV, reversed 2018 in another hospital, and that was patient's documentation of his procedure 2018. So after, I think, 1-2 weeks after the procedure, in the below-the-knee wound, he developed a wound healing disorder, which never healed till he came to us. And he had nearly 20 procedures on the wound, a superficial procedure or revision, deeper, and always the bypass was patent. So he had any arterial problems on the right leg. And the problem was the wound healing disorder plus a severe lymphoria, also patient's private documentation, and a severe PTS. So that was patient's leg as he came to us, also with the drainage. He received drainage, they removed the drainage, and he had a lot of procedures. And the end stage was swelling, pain, hyperpigmentation, and a severe venous claudication, full picture of PTS. So we went for a venous map by duplex in supine and upright position. You see the post-thrombotic changes in the iliac tract and also involving the common femoral vein. Luckily, the patient had a very good inflow from femoral vein and deep femoral vein. So the problem was patient had also a big reflux in the GSV.
Can I stop you here, Houman?
Yes.
I need to stop you here. And maybe I ask also Nikos. So you indicate that there is also great saphenous vein incompetency.
Yes. What you can see also in the running axial plane of MRV, here you see the occlusion, here you see the huge GSV on the right side. The left GSV was harvested for the bypass.
Okay, it is clear. Nikos, can things get worse if we ablate the great saphenous vein?
In some cases, yes, Mike, it's because the amount of reflux is small. And then, the vein is very dilated. So, but if a patient has a saphenous gross reflux, then you don't really lose anything. But also this picture will be very important. You should, if you address the vein, you should not touch these collateral veins in here, because these veins in the junction here, they promote, really a nice bypass flow. So if you are to treat and encopy the saphenous vein, you should leave these guys intact and make sure that the vein has really gross reflux, not like, half a second or 1 second reflux.
So is it a mistake if somebody ablates the great saphenous vein first in a patient with a venous ulcer?
No, if you think that the vein is like from the groin to the ulcer with a lot of reflux, right? Nothing to lose.
What is a lot of reflux? How do you define a lot?
Well, let me give an example. The obvious ones. The patient should not be touched if the vein is 7 or 8 millimeters and the reflex 0.7 seconds.
Okay.
Right? Yeah. Then the alternative, the same diameter and the reflex 5 seconds. Then that patient should be treated.
Okay, that's clear. Houman, continue.
So, I don't know if I can interrupt Houman.
Of course.
Sorry very much, but I think this is an important point regarding the GSV ablation. Could be more clear about this because it is a very important point. To my opinion or to my practice, I never ablate GSV if I have an obstruction of the system, but if they are both incompetent, I ablate the great saphenous. What do you think about this?
I do exactly the same, Giovanni, exactly the same approach. If we have a clear occlusion, a PTS obstruction or occlusion, we do not touch GSV even. As we know, it is the smaller procedure, you can do it ambulatory, very fast. We do not do it because from the physics, the higher venous hypertension is created by the occlusion. And the problem is on the occlusion. Why should I treat the GSV and create another insufficiency reflux in the superficial system probably 6 months later or 1 year later? If I can treat also with small morbidity the venous obstruction, I exactly do the same. If that would be a reflux in the deep and reflux in the superficial, I would go for the superficial first. As we know, the treatments for the deep venous reflux are not very proper.
Houman, very quickly, if the patient has just a small ulcer, treating the saphenous may be fine. But if the patient, edema that extends in the middle of the cuff or above, or extensive skin damage or a large ulcer, then
yes,
definitely address the obstruction.
Very important. Yeah. He had the full picture of advanced PTS with venous claudication. He will talk later. I will show it to you. So we went for the recanalization. I hope you can see the video. Maybe I accelerate it here. Very important supine position in a hybrid procedure, hybrid room. My junior colleague, Dr. Babati, is the duplex guided, is puncturing the mid-femoral vein. You see the leg, swollen leg, big leg, and a PTS leg. So then we go inside. Everything is an AP view. You can take a lot of, wires and catheters. As you know, it is not only because we use the Terumo, you have to use it. So you have a lot of options to recanalize. But normally we use the Terumo stiff, angled 180, 0.35, supported by a catheter, as you can see here. Then we go a little bit farther with many techniques. The video is short enough. Of course, the case took us 2.5 hours. Now, the normal vertebral catheter, it was not possible to traverse the pathology. We took a quick cross, which is a support catheter with a better shape, with a better profile. Even then, you see extravasation. Makis, would you be afraid for an extravasation in a venous recanalization? Very fast?
Not really. These are low flow systems that will typically stop on their own. And if you're concerned, you can inflate a balloon for a couple minutes and it goes away.
Exactly. So thank you, Makis. Exactly. We did the same. Now we went into the oblique projection, you see, and then we give a new dye to see maybe a new way. So be patient, use all techniques. And now I reverse the 0.18 Terumo with a stiff tip. I take a needle holder, and this is a sharp recanalization, which you need sometimes. Of course, you have to respect the anatomy, the technical aspects, to not puncture or go through the artery. I achieved probably 3 centimeters of a new channel, and then I gave a new contrast. And with a normal tip of a stiff wire, now I can traverse the pathology, as you can see here. So after it, we take a 8 millimeter balloon just to fix the channel. I achieved with a sharp recanalization, and I dilate the balloon. With this technique, we can centralize the lumen we achieved, and then with the help of those techniques we used, now the pathology is traversed and the wire is going into the IVC. So after traversing the pathology, you have to pre-dilate the entire pathological tract from the good inflow to the good outflow. And We did that, as you can see here, with the Atlas Gold balloon, a high-pressure big balloon. After this, you have to use IVUS additional to your phlebogram in order to precisely determine the proximal landing zone and the distal landing zone. This is very important. You cannot just put the stent somewhere to somewhere. It is exactly needed that you determine by millimeter your exact landing zones. So now visualization of the cava confluence, as you can see, then we decided for a 16 to 120 dedicated venous stent. The first venous stent is precisely deployed, as you can see here. And you see that the predilation is necessary to rupture all those scar tissue in order to give a chance to the stent to deploy properly. Now, the first stent is deployed, then we measure the length of the second stent. We again determine the distal landing zone, and we go for the next stent. This is the predilation again. You see the IVUS, determine the distal landing zone at the level of the deep femoral vein. With IVUS, you can also measure the length. And now we go for the second stent, as you can see here, which is a 14 stent for the extension, and have a look on the distal landing zone here, which is exactly above the deep femoral vein. So the good inflow is coming into the stent and go through the new highway into the IVC. So, and after post-dilation, we give a dye. There is no collaterals anymore. The contrast is running. And of course, you need another run of IVUS intravascular ultrasound. This is mandatory. So today, 2024, if you would like to do recanalization, you need also an IVUS in your hybrid room or in your angio suite. So the IVUS shows a perfect geometry and position of both stents. You see how nice the stent geometry is. The occlusion is treated. We have a good inflow. Now the IVUS arrives at the distal landing zone. Just have a look, and there is the deep femoral vein. So perfect distal landing zone, good proximal landing zone. And hopefully, patient is doing well here before the starting angiogram. You see the collaterals. Very important, Nikos and Giovanni and all participants, have a look on the GSV reflux. Look, that is very important here. A clear GSV reflux. And then we go for recanalization, predilation, and stenting, and have a look on the GSV reflux now. Nearly gone in comparison to before recanalization. So that was patients post-op before discharge duplex. We measured diameter, area, and everything is detected. That was patient's leg in our outpatient clinic before the procedure, 2 months, 3 months after the procedure. And hopefully I have time for 1 minute asking the patient in our outpatient clinic. I think that was 3 months after the procedure. He's speaking German, but it is written in English.
Aber es regelt große Einfluss bei. Sogar im Laufe der Zeit zu einer Lungenentzündung. Vor der Stent-Operation hatte Peter Glaubitz massive Probleme. Sein Bein war extrem angeschwollen. Also fast doppelt so stark wie normal. Da kann sich laufend sehen.
So venous claudication. So that shows how involved and impaired the patient was in his daily life. Yeah, walking distance of 20 meters, 30 meters. Thank you very much.
Great presentation, Houman, as always. Thank you. Thank you for the technical tips. I'm not going to go too deep into technical interventional. We're going to hear more details during Venous Symposium Europe. And since we already had some discussion, I only have one question for you. What is your anticoagulation regimen following the procedure? And what are your compression suggestions to the patient in general, and specifically when you also have arterial disease, like in this patient? How do you handle compression?
So let us start with compression. So first of all, there are enough literature sources showing that if a patient has a venous disease and arterial disease, you can administer the patient compression stocking grade 2, unless the patient has a real critical limb ischemia. That means his ABI is below 0.5, 0.6. That means a patient with a normal PAD in whom you have a 0.8, 0.9 ABI, you can easily give the patient a compression stocking grade 2, which we do. After recanalization, all of our patients, they have a compression stocking in the procedure room, in the hybrid room, and then they should adapt it, because immediately after 2, 3, 4 days or 2 weeks, the swelling of the leg is decreased, so they have to change it again. That is a little bit a pity, a logistical problem, but they need a proper compression stocking. And at least we go on for 1 year in chronic venous obstruction patients. But we change it from month 1, 1, 2 to a knee-high level compression stocking grade 2. Regarding the anticoagulation, all patients receive 2 weeks of low molecular weight heparin because of the anticoagulation aspect and anti-inflammatory aspect. After 2 weeks, we change to new oral anticoagulation. We use rivaroxaban for at least 1 year. If the inflow is impaired, probably longer or lifelong. But in this patient, in this case, with good inflow, after 1 year, we stop the anticoagulation.
Thank you, Houman. I don't see any question coming at the chat, so I think we can move on to our next speaker.